Sir, you are in live. Please start your
Okay,
session.
thank you. Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar, as you know, is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993. We have 30 years of excellence in 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, FDA, APIs, and FDFs in the world, and has Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare, a 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneer in antivirals, offered the patients oseltamivir, favipiravir, and remdesivir, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of oseltamivir in flu management. We have got Dr. N.L. Sridhar sir as our moderator and Dr. Pawan Kumar and Dr. Sankoj as our speakers. Welcome Dr. Sridhar, welcome Dr. Pawan Kumar, and welcome Dr. Sankoj. Dr. N. S. Sridhar sir is practicing since 20 years, is Professor Apollo Hospital of Medical Science and Research, Director Neo BBC Hospital, Hyderabad, Treasurer Secretary, Twin City Branch, 21-22, 23-24, Joint National Coordinator, CIAP 24-2025, Presidential Action Plans, Secretary PITS, 25-26, Medical Legal Expert, major achievements in, has published articles in 7 national and 1 international publication. Additional Chief Organizing Secretary, Pedicon 2025, Organizing Secretary, APPA Pedicon 2016, Pharma Trade in Charge in all conferences since 2016, Vaidyaratna Award 2023 from Dr. B.C. Roy, Mother Fount. Welcome, Dr. Sridhar. Welcome to this webinar.
Thank you.
Dr. Pawan Kumar, sir, is Professor of Pediatrics, MNR Medical College. Sir is Consultant Pediatrician, Omega Clinics. Scientific Convener, National Pedicon 2025, National Advisor, Indian Pediatrics Journal. Sir has fellowship in allergy and clinical immunology, postgraduate diploma in pediatric nutrition, postgraduate diploma in developmental neurology, and has won several awards, just to name a few: Bharat Gaurav Puraskar 2023, Best Pediatrician of the Year Award 2023, Vaidya Ratna Awardee 2015, OGU Outstanding Academician of the Year 2023, Dr. APJ Abdul Kalam Health and Medical Excellence Award 2021, Asia's International Researcher Award 2023, Best Researcher Award 2016, 2018, and again 2022 and 23 by MNR Education Trust, Dr. Y.R. Reddy State Gold Medal, and Dr. Chandrasekhar Chowdhury Gold Medal recipient. Sir is National Award winner of Dr. V. Balagopal Raju Gold Medal for Scientific Research Paper 2010. Welcome, Dr. Pawan Kumar. Dr. Sankoj Bhaskar, sir, is the Director, Paramita Hospital for Women and Children. Sir is working as a consultant pediatrician since 1989, more than 35 years of experience. President, Pediatric Association of Telangana State, 2025, PATS. Intensive Care Chapter of Telangana State, PICCKTS, 2023. Welcome.
I think Prashant's connection is unstable, I think. Can I start, Prashant?
Yes, please.
Yeah. So, very good afternoon. First of all, I want to thank Hetero team and Hetero Healthcare for giving me this opportunity for my team. And a legendary panelist, Dr. Sankoj Bhaskar sir, who is the president of Pediatric Academy of Telangana State, and my friend Pawan Kumar, he is the professor of pediatrics in MNR Medical College, and also a senior most consultant in the Kukatapalli Housing Board. And really, they can enlighten you about the case histories, cases, and other things. Coming to the brief introduction, let me share the able to see?
Yes, sir.
Yes, sir. Yes.
Yeah. Yeah.
Perfect,
So
sir.
today's topic is a very much interesting topic, need of hour of things, role of Oseltamivir in flu management. And my panelists, I welcome Sunguj Bhaskar sir and Pawan. And under these four main headings, the contents are healthcare challenges in monsoon, their diagnosis, influenza, which is commonly known as flu, and its complications, and also clinical evidences of Oseltamivir, and guideline recommendations for empiric use of Oseltamivir. Under these four headings, so before starting, let me tell about a brief things on the influenza virus, where how it causes, what are the types of virus, and what is the diagnostic criteria, and what things will be diagnosis will be done, and what is the best drug to be given for this. So a brief introduction will be given. So you know very well, since we are having monsoon, extended monsoon in Telangana and South zones. So the influenza like illness and influenza is more seen in nowadays in the cases. So we have to, there shouldn't be any confusion between influenza and influenza like illness, and similar presentation can be dengue or gastroenteritis because of the other viral causes. There are few viruses which has to be differentiated between influenza. One is most RSV virus, and also adenovirus and rhinovirus. This should be keep in mind. So in these conditions, the patient will not be that much unwell, and the other differentiated features are myalgia, weakness, and headache will be more in influenza. So in this way, we have to differentiate these things. And moreover, the criteria, you know very well, any viral disease is a self-limiting. But if the severity is there, definitely we have to handle that case and we have to treat that case. So mainly the diagnostic criteria, two or three are there. One is RT-PCR is there, a little expensive. There is a multiplex PCR. And second is flu panel test, which can we get it in 24 hours, and the panel can reveal the positive of influenza A or influenza B, and also subtypes H3, H1N1 or H3N2. We can both can be seen in the panel test. And in Indian data, common the 5 to 10% of all are due to influenza. 10 out of 100 child year suffers from influenza, and also there is an instance of 180 to 178 per thousand children per year below 1 to 2 years. And there are two different studies which have taken in North India, and influenza associated with acute respiratory illness 33 to 44% per thousand children per year. And you know very well, two pandemics we have seen. One is 2009 and 2019 up to March. There are 30,000 positive cases are there, and around 1,800 died. So this is the diagram which was taken from the Purple Book of Vaccination from the Central IAP. IAP had given this book. So in that we have seen two peaks when the influenza is maximum incidences of cases are there. One is January to March, and second is July to September. In these two areas, out of 3 months, 3 months, 6 months, the influenza incidence of cases will be more, and we have seen post-monsoon cases also. And coming to the mortality, morbidity, and hospitalization due to influenza, lower respiratory tract infections, the statistics is a global burden of disease 2017 has taken, and you can't believe, sir, 5,88,000 cases are hospitalized and 26,000 deaths are there. And year-wise, the cases, incidence of cases and deaths are formulated. In 2022, we have a cases of 12 registered cases at 12,881, and deaths are 399. I feel the flu panel is done in the corporates, in outside also in few clinics, but those cases are not reported to the medical officers, DMHO and district medical health officer. The message to pediatricians: if any H1N1 or H3N2 is positive, in flu panel, kindly inform nearest DMHOs so that they can the statistics they can add into the statistics. And this is the pattern of circulating strain of Indian varies. Northern India peak is January, March, what I have shown. Central India, that means we are in Central India. So July to September, Southern India, September to November, and in winter and monsoon, peak occurs in these two times. So there is a study of 7 years cumulative study in Tamil Nadu in King Institute of Preventive Medicine and Research. There are 36,670 specimens are collected and subject to influenza analysis and duration of 7 years. This is a study duration, and influenza positivity started with the onset of monsoon and peaks during the post monsoon months. This is a study for 7 years. And there are differential diagnoses. We should be careful whenever we see a case of influenza, cough, cold, fever, and dull, myalgia, headache, and body pains. We have to keep in mind these four differential diagnoses. One is influenza-like illness and present influenza H1N1 and severe acute respiratory illness. And also because say in 2020 we were total world was affected with COVID-19. This is the differential diagnosis, but COVID-19 will be having a multi-system involvement, having along with respiratory symptoms, gastro symptoms will be there, and also headache and a few more breathlessness and disorientation. These are all the there's in the COVID-19. So this is the static bar diagram which had shown instance of influenza and related deaths year-wise. The dark blue color is 2019. You can see 28,798 cases registered and 1218 is the death. So coming to the types of influenza virus, influenza A causes frequent epidemics and influenza B affects only humans, but local epidemics are seen. But influenza C can affect humans and swine, but doesn't cause any like epidemics or pandemics. So currently circulating humans subtypes are H1N1 and H3N2. So how to transmit this? Transmission of flu virus occurs. People with flu can spread it to the others by 6 feet away, and due to the droplet infection, they land into the mouth and nose of the people, where inhaled into the lungs. That can cause inflammation of the lungs, alveoli, and pulmonary things, and then the inflammatory process will increase and cause the problem. So this is also the main affected person and stay home if sick, and also the important to wash hands and often with soap and water. This is more important, sir. Most healthy adults may be able to infect other people beginning 1 day before the symptoms develop and up to say 5 to 7 days before becoming sick. So with the, as I earlier said, the differential diagnosis between influenza like illness, H1N1, and severe acute respiratory infections and COVID-19, this is the differential diagnosis where symptom wise which are common in what condition. So the breathlessness it may or may not be there in influenza like illness, but it will be present in influenza and severe respiratory infections. And but one most important, as earlier said, COVID-19 will be having loss of smell and loss of taste and GE symptoms. And one here, this most important last, headache is most important in influenza. May or not present in influenza like or severe acute respiratory or COVID-19. But in influenza, headache and myalgia, body pains, and these are very much weakness will be seen in influenza. And benefits of empiric and early use of Oseltamivir, definitely it affects, reduces the lower respiratory complications, antibiotic use, and hospitalization. By antibiotic use was reduced by 26.7%, and influenza related lower respiratory complications had decreased to 55%. It's good to listen. Hospitalization was decreased by 59% because of the Oseltamivir treatment will reduce, because prior within 48 hours if you start the antiviral drug Oseltamivir, which is a beautiful drug, golden drug now. Only few drugs are available antiviral for this influenza. One is golden drug is Oseltamivir, where it will reduce the hospitalization and antibiotic use. And with this brief introduction, now the case scenarios, I request Mr. Pavan, Dr. Pavan, to take up the first case and enlighten the public. Please go ahead.
Yeah. Thank you, Sridhar sir. Thank you, Sankuch sir, and thank you, Prashant sir. for giving this opportunity to interact with our own colleagues, our pediatric fraternity, about the most common thing which is happening right now. We are already surrounded for the past 2, 3 months with the flu season going on. Almost it's like an epidemic here. So it's an outbreak which has happened. And we are going to discuss one of the frontline pharmacological defense against this influenza viral infection. So, dear friends, this is one of the commonest case scenario, the real case scenario. 4-year-old boy Rajesh admitted with the fever for last 6 days, along with cough and cold since 5 days. So, this is the commonest scenario, right? But when we check the respiratory rate of this child, it is 45 per minute, which is more than that age. And what is more irritating is that irritability. The child is having irritable. So the parents were really they want a doctor consultation immediately, and they came to the clinic. So on auscultation, we can clearly hear there are bilateral crepitations. And if you see, his weight is normal, 15 kgs for a 4-year-old boy, which should be ideally 16 kgs. That is a well-thriving child only. So then how do we proceed? What should be our initial management? What are the basic investigations in the routine practice? Do you start antibiotics on the day of admission? If so, which antibiotics? So these are the commonest questions a pediatrician is usually faced when they encounter this. Because this child is sick, irritable, and also tachypneic, and there is an increased work of breathing, this child was admitted as a child is very sick, and we need to start oxygen in a convenient method and a non-threatening manner. Please remember this word non-threatening manner, because a child who is having a respiratory distress, if he cries, if he is not comfortable, then that will aggravate his hypoxia. So that is when we need to give in a convenient non-threatening manner. We should not force that mask onto his face. Nobody likes that, thrusting the oxygen mask onto the face, but we should allow the mother to handle the such a situation, and we should allow in a most convenient manner. We need to deliver the oxygen, which is very, very important in case of respiratory distress with hypoxia. And we need to give a supportive care. We all know that first drug is oxygen, second drug will be the IV fluids to support the hydration. Most of these kids will be dehydrated because of lack of intake of food and water. So that will make them more for a dehydration. And definitely we need to do the basic investigations. Please don't hesitate to tell the parents to do a CBC, which will give us a lot of clues. It will, if there is a neutropenia with a lymphocyte predominance, so that will give us a more likely the child is having a viral. And if there is a CRP negative, with despite high fevers and all, so that will also give this child is having a most likely a viral. And chest X-ray, don't hesitate to take, because it doesn't cost much, 300-400 rupees only, but that will give you the parents the confidence that you are thoroughly investigating the child. So they will feel that, when the child is having breathing difficulty and all, doctor has really done chest X-ray also along with the auscultation. Good auscultation is very important. Please spend at least 30 seconds to auscultate his lungs. Okay. At least what I ask in my clinic is ask them the kid to take 10 breaths. So most of the times you may encounter that, when you auscultate also, the parent will tell you that once again check, did you auscultate it, sir, how are the lungs that? Even though they observe us doing it. So verbalize when you are checking the lungs, tell that, ask the child to take deep breaths, and immediately give that inference to the parents that, the child lungs are clear or there are some crepitations or not. Because parents will be in different world, so they may not observe you checking the lungs. So they will be thinking that you didn't check the lungs properly. So verbalize your actions, whatever you action, then verbalize that and give an inference at the end of the auscultation also. Yeah, yes. Do you start antibiotics? Definitely, because this child is having sick. We don't know what other things are there. Until there is a clear-cut evidence of no other secondary bacterial infection, as per the MNCA guidelines, we can start as an amoxicillin as an oral antibiotic. But once the confirmation has come based on the CBP, X-ray, and even the sir has clearly told, short viral panel in Hyderabad and Kukatpalli, it costs only 3,600. Within 24 hours, you will get whether which virus is positive. And this child X-ray is CBP is normal, and chest X-ray shows that bilateral interstitial infiltrate. This is what we are seeing daily, day in and day out. And the viral panel was also done for this child on OP basis, but the child has got this H3N2 was positive for influenza A. Now we have a wonderful drug, the primary, pharmacological defense that we are going to discuss now. Antiviral drugs, please don't hesitate to use, dear friends. The Oseltamivir is the one of the wonder drug. I can say that, it works like a magic. Don't, be afraid of using this. This is an FDA approved drug. Whenever you suspect that, please don't hesitate to use it. So what is the advantage of giving antiviral drug? So it can shorten the illness if started within 48 hours of symptoms, and it should be prescribed. And because we all know that once it is viral, there is no role of antibiotic. It's like, opening our home door with the neighbor's keys. It will never happen, right? So, and it should be, dose is also very important. I request all the pediatrician to please remember this dose. 3 mg per kg per dose in the oral form, twice daily for 5 days should be given. That is definitely be effective, and it will reduce the symptom duration by 1 to 2 days. It will decrease the risk of severe complications also, which requires hospitalization. As Sridhar sir was nicely told, it will reduce the hospitalization risk by 59%. What more we want? And it also, death rate is also, we have seen that, lower mortality rates in the high risk groups, especially. And luckily, hetero group has brought us a syrup formulation. So, which is very convenient to use for the pediatric age group. And also, please, whenever the parent comes with that scenario, please write a red flag signs. Don't hesitate to write the red flag signs on the prescription itself. When the child is having fast breathing, bluish discoloration of lips and, fingers. And most important thing is not active, playful, not drinking enough fluids, not at all eating properly, then that is when we need to really act on that child. Please write it on the prescription, write the red flag signs, and ask the parents to come back if any of these symptoms are noted. Next slide, sir. So we need to really know about the severe acute respiratory infections, other complications of this flu. It can cause simple ear infection or worsening. This is very important. In next scenario, we are going to see how this flu can worsen the existing chronic diseases like asthma and COPD. We need to protect these children who are having with asthma and COPD there. And ARDS is one. Once ARDS sets in, the mortality rate will go up like anything. So let us prevent that by giving the antiviral medications like Oseltamivir as early as possible, so that will prevent it. And see that what is the commonest treatment? We need to give the child bed rest, increase fluid consumption every second hourly, third hourly. Give a dose to the parents that every second hourly try to give the water, at least plain water, lukewarm water to the child, so that will it will reduce that mucus thickness and all, so that the child will be able to breathe properly. And cough suppressants is a big debate. So nowadays we are getting a lot of things that, everybody, parents are scary because of giving cough suppressants and all. So when needed, above 4 years, we can use some certain drugs. So antipyretics and analgesics are already there. Paracetamol is one of the simplest thing which we can use. But if you feel that the child is having high grade fevers with myalgias, don't hesitate to use a NSAIDs as and when need basis. And most patients with influenza recover in 3 days. Nowadays, we are also seeing other viruses like respiratory syncytial virus, which is taking almost more than 10 to 15 days for the child to recover. And I've seen the RSV is making the children less than 1 year to admit into the ICU also. So we need to differentiate whether it's a bacterial or viral. In viral, which is it's an influenza or RSV or adenovirus, which is rampant now in Hyderabad. Next slide. So I request all of you to pay attention for these two wonderful drugs. One is neuraminidase inhibitor, that is Oseltamivir, and there is adamantins, which are also not frequently available, but that is also available. These adamantins, usually they block the entry into the host cells, the virus itself. So it is, but unfortunately, it is active only against influenza A. So that's why most of the viruses which we see in the reports also, it's more than like influenza A and B both together we are seeing. So we need a drug which will address both of these, right? So how it works? This is a very interesting scenario you can see. So how this works is a very important aspect which everybody should understand. So once this virus enters and replicates using the genetic material, using the host itself, it will feed on the host and it produces new virus particles inside the infected respiratory cell, which is being shown there. But what is important is the neuraminidase protein. The neuraminidase protein is what is important, which cleaves the sialic acid, the binding protein for the virus to get released into the, and then only it will go and continued virus replication. It will go and infect other healthy cells and all. This oseltamivir, the down slide, if you can see, it competitively binds the neuraminidase active site. the neuraminidase active site is being blocked by the, yes, sir. Yeah, the sir is showing there. So these neuraminidase inhibitor will block that sites and blocking the enzyme function and thereby prevents the release of the host, release from the host cells. It's like, terrorists being camped and we know that and we have locked them up so that they won't come out of the country and damage the country. So that is where the oseltamivir role has come up. And thereby, what happens once the release is stopped? So thereby, it cannot infect the neighboring cells and it will also limit the viral replication and thereby reducing the symptoms severity and also transmission to others. These two advantages, severity will go down in that child and it will also prevent the spread to the other persons. So that's why it's always better to use this drug. And please remember, it is usually the prodrug is oseltamivir carboxylate, which is converted into liver. It will excrete it through renal. So we need to, in renal impairment cases, we need to adjust this dose also, that we need to keep in mind. Okay. So this is a potent and selective inhibitor of neuraminidase enzyme, which is a selective indicator, and it works best with influenza A and also B. Next slide, sir. So this is the first oral neuraminidase inhibitor, thanks to Hetero for bringing up this Fluvir, and they have, this is approved in more than 100 countries, which is approved by American Academy of Pediatrics, CDC, and also FDA. Over to sir.
Yeah, thank you. The first case is a beautiful play, easy to, if you are, that's why what senior professors say, clinical acumen is to great extent. Clinically, we can diagnose the case, and if needed, only we can send the panel. If the panel comes negative, also better to start empirically oseltamivir, which inhibits the virion release, and the virion will not have infect the healthy cells. That's the main oseltamivir action mechanism of action. So nicely described by Pawan. And next case, Dr. Sungoj Bhaskar sir is the president of Pediatric Academy of Telangana State. Please, sir.
Yeah. Good afternoon, my dear learned faculty, Dr. Sridhar, Dr. Pawan. And I sincerely thank Hetero family for bringing out this very relevant, useful academic discussion on this ongoing seasonal fevers, particularly influenza viral infections. So recently we had seen a girl, 6 years old girl, came with fever and running nose since last 6 days and cough since last 3 days. And when we took the history, this girl is a known asthmatic, but on irregular treatment. So when we examined this girl, there were bilateral crepitations with mild wheeze was there. So as we expect, these creps and wheeze was there. Creps we can think in terms of like increased bronchial secretions, whereas mild wheeze because of the bronchospasm, which are seen in asthmatics. So here interestingly now, should we suspect viral infection, that is flu infection in this child or not? So if so, what is the criteria? And as there is a past history, is it a simple post-viral asthma, which may require only bronchodilators, but not antivirals or antimicrobials? So first thing is we need to suspect flu infection in this child because now the season is ongoing. Dr. Sridhar, slide has moved away. Am I audible, Dr. Sridhar?
Sir has left, I think, sir. I think maybe
Dr.
signal issues
Sridhar,
with the
yeah,
sir.
yeah. Dr. Sridhar is logged out. I think he'll log in again. Some
Yeah,
network
Sridhar
issue, I
has joined.
suppose.
Yeah,
Yeah, it's come back again.
Sridhar sir has back.
Yeah. I don't see Sridhar, sir.
So here in this girl, we need to suspect viral flu infection because now the season is going on. We are seeing almost like in epidemics, probably across the nation due to these heavy monsoons. And secondly, we all know any viral infection can worsen the asthma, which is already pre-existent in this girl. So next slide, Sridhar.
Yes, sir. Sorry, sir.
So any virus, any virus can trigger asthma, more so this influenza virus. We all know asthma is an airway inflammatory disorder, and as well, virus will also cause inflammation when it infects the airways. So the virus infection will worsen already the pre-existing inflammatory problem. So that's the reason why whenever there is a virus infection, the asthmatics will have more asthma. Whereas in our case, this girl became febrile, became more active, cough has decreased, but this tachypnea retractions had worsened. Even with simple oxygen, we were unable to maintain saturations. Then we had to put her on HFNC for 6 days in PSU, and with great difficulty, this girl came out. Uh, she became normal, no breathlessness. So we discharged her. So message here is, if viral infection, particularly influenza infection, infects any child with pre-existent airway disorder, particularly asthma, it can worsen them. That's why then we are advised that girl to have annual vaccine without fail. And secondly, and she should be on meter dose inhalers. Next, please. So, what are the recommended guidelines by WHO? So, World Health Organization clearly states that you can start the antiviral treatment empirically if you strongly suspect a respiratory viral infection. That is our presently now we are seeing mainly H1N1 and H3N2. There you should start Oseltamivir, a good neuraminidase inhibitor drug, which is really doing very good with the children. Once you suspect viral respiratory tract infection, particularly during this season, do not hesitate to start Oseltamivir empirically. And we can as well, we do some other investigations. And once we get the confirmation, then we can decide whether to continue or not. Even when you are in doubt, please continue antiviral Oseltamivir for a period of 5 days, because negative lab test for H1N1 does not exclude the diagnosis in all patients. There is an increased incidence of false negative reports with even RT-PCR. So whenever there is a higher risk individual who is exposed to a patient with influenza, even there you can consider it as a prophylactic, a chemoprophylactic drug, and it should be used in those high risk groups who are exposed to these patients who are suffering from influenza infections. Next, please.
Yes, sir.
So, as we stressed earlier by our moderator at Sridhar and Dr. Pawan, do not hesitate to start antimicrobials empirically to treat all likely pathogens causing severe acute respiratory illnesses. And it should be based on your clinical diagnosis, whether it is community acquired pneumonia or a nosocomial infection. So if it is community acquired pneumonia, better to start Oseltamivir immediately. Or even if patient comes little later also, do not hesitate to start, because it's clearly shown that if you start within 48 hours, you'll have very good outcome as far as complications are concerned and hospital duration of stay is concerned. Uh, Definitely it's reduced. Even in nosocomial infections, it can be tried. So the empirical therapy is mainly this neuraminidase inhibitor for the treatment of influenza when the season is going on, or in a child who has all these high risk factors, pre-existing illnesses or comorbidities. There we need to use this neuraminidase drug Oseltamivir therapeutically and as well as prophylactically. Next, please.
Yes, sir.
Slides are not moving.
Sir, చేశాను సార్.
Yeah, slides are not moving.
సార్ ఇప్పుడు
Yes. Yeah, now visible.
Ah,
Visible. So even in adults with community-acquired pneumonia who test positive for influenza, we should start antiviral therapy. That is, oseltamivir should be prescribed who test positive for influenza. Not only positive, even where you strongly suspect clinically, there will not be much harm if you start oseltamivir. Rather, you will be benefiting the patient by starting it early. And so many studies to suggest the treatment with oseltamivir is associated with the reduced risk of influenza complications, duration of stay in hospital, even it has reduced the risk of death in patients who are admitted for community-acquired pneumonia with confirmed influenza virus. And as we, once again, we stress treatment within 48 hours of symptom onset may result in best outcomes. If it is delayed, do not hesitate to start because even there you have some benefits, if not so as much as it is started within 2 days. So in this child, we after examining clinically, we took chest X-ray. It was showing bilateral interstitial infiltrates, not very significant, but lungs are hyperinflated for two reasons. One is this viral respiratory infection, and secondly, this child is an asthmatic. We did CVP; it is normal as expected, and CRP we did, though we didn't mention here. It's again normal. Then we sent for this RT-PCR, and it was positive for H3N2 influenza A. So now it's a confirmed case of influenza infection with a pre-existing illness, asthma. So the child was given oseltamivir along with asthma treatment, but it took a lot of time, almost 6 to 7 days. Child had to be kept in ICU with HFNC. And once child became stable, we sent the child with the metered dose inhaler therapy.
okay. Thank you, sir. So this is the case of coexisting condition of asthma along with the influenza virus infection. So the influenza or flu-like illness will definitely aggravate the asthma if the child is a pre-existing condition. So what happens is we have to balancely treat both the conditions, influenza condition and also asthma condition, where Oseltamivir was started and child was improved and kept on asthma treatment and discharged the child. So coming to the third case, Dr. Pavan, can you please?
Yes, sir. Yes, thank you, sir. This is another common scenario, dear friends, how we can treat this 2-year-old boy who was admitted with high-grade fever for 2 days, along with cough and cold for 2 days. What is most important is the breathlessness. These days, we are seeing we are not getting these children very late also because within 2 days, the child is becoming breathless and cough is so severe that parents are not able to tolerate the kid at home. So that is what really inspires us to be, they are getting the child little early only. And the fevers of not less than 103 is making them to rush to the hospital as early as possible. So that is giving us an edge. So they are these days nowadays we are not seeing them coming in late stages. After within 48 hours they are observing at home, still not responding. Immediately they are rushing to the clinics. So what should be the initial management? This child is a 2-year-old child with a 60 tachypnea. I think definitely it's a tachypnea and with high grade fever. I think this child should be admitted first. Next slide, sir. So this child is having RD and please start life supportive measures immediately. That is oxygen support. I told you it should be delivered in a non-threatening manner. What is most important is the child who is having a breathlessness and severe cough, not even stopping for 5 to 10 minutes. Always this HFNC is really helping them a lot. So it is almost reducing the hospital stay by 2 days, I can say. So that is what HFNC is now is a non-invasive way of giving this ventilation support. Please don't hesitate to start HFNC as early as possible. And the role of presumptive antibiotics, yes, till the diagnosis is confirmed that it is a short influenza without any bacterial or secondary bacterial infections. So always better to start antibiotics as per our hospital policy and also by IMNCI guidelines. So do you want to start preemptive anti-influ therapy? Yes, definitely. I would love to start because when the child is having one clue here, dear friends, what I see in routine practice, if the child is coughing, the severity is the more during day and night, it's equal. When the parent says the cough severity is more during day and night, there is no gap, doctor. The cough is worst even day and night. It's worst, doctor. I've not seen the worst cough like this in my life. Bole to then think of always the viral, the influenza especially. So it will not give a cough which is manageable at home. It will definitely trouble the not only the child but also the parents, also the neighbors also, because the child will be continuously coughing and that the crying and coughing. So please, when you see that scenario, don't hesitate to start antiviral. Start it as an empirical treatment. Now we have the guidelines which says that you can start it empirically because the outcome will be the best if you start it as early as possible. Even the AIM study says that within 36 hours, if you can start, the chance of hospitalization, the child going into death rate is also has come down, and the hospitalization risk also come down by almost 59%. So that is where we need to don't hesitate to start preemptive antiviral therapy. These are the indications which are commonly suspected. Even if you suspected influenza-like illness and the child is having a breathlessness, cough continuously and not able to tolerate, please don't hesitate to start. And confirmed influenza cases, when we investigate, I think this child also will have a report. I will show you that. Have underlying conditions, especially the children with asthma, like the previous case we have discussed very nicely by Sunkotsa. So that is very important. Underlying complications are there. A child with chronic diseases, respiratory diseases, or cardiac diseases, and renal diseases. These children are more susceptible to these. So we need to start them without any second thought. And antiviral treatment should be initiated as soon as possible and regardless of the duration of illness. Even though the window has started, if we didn't start in 48 hours, still it is beneficial. Even if it is still before 5 days, also, if you start antiviral, that is really reducing the mortality and also the morbidity. So here in this child, the X-ray, you can see bilateral interstitial infiltrates are there and lymphocytosis. This is an important clue which you can catch in the CBP. Simple test like CBP can give you. This is more like a viral and most likely influenza. So lymphocytosis with neutropenia is a clue for us. And viral panel for this boy showed H3N2 for influenza, which is detected. So which is immediately without any hesitation, we need to start Oseltamivir. What is the dosage? This is very important. Just take a screenshot and keep it on your desktop or laptop, or in a tabletop you can put it, because nowadays we are seeing every other day, every third child is suffering from this influenza. So you can see even not only the children, but the parents, if you ask one question, is there anybody in the family is also having the symptoms? Yes, they will tell. Definitely you will get an answer that mother, father, or another sibling also will be having that. So we need to do the dosages for everybody. Adults, it is 75 mg capsule twice daily. But when it comes to prophylaxis, it is always once a day. Please remember that. And there is a age bracket, different weight brackets. What is the dose? How much ml is nicely framed by Sridhar sir in one slide here. I think this slide is most useful slide of the entire deck. So keep it ready. And if you find any weight child, 3 mg per kg twice daily, it should be given. If it is a 2 weeks to less than 1 year of age. So chemoprophylaxis is not applicable for this less than 1 year children. But that is the dosage. Please remember 0.25 ml per kg. You can calculate easily with that. And the parent has asked me, like, this child is also having another 5-year-old sibling with a nephrotic syndrome and who is on steroid therapy. So they will ask immediately, because we have suspected and the case has come as positive for this boy. They will tell immediately, they will ask you question. What they will ask you, doctor, can I take flu vaccine for this child? Because the other child is already suffering. So can I give flu shot for this child? So which one you will choose? Do you give antiviral drug here or influenza vaccine? Because once the parent knows that one child is suffering with the flu and admitted in the hospital, they want to protect this child who is a really precious child. I think because of his comorbidities, nephrotic syndrome, who is on steroid therapy, which will cause the immunosuppression. This child is more likely to suffer than the other child. So we need to. There is no role of vaccine for the child who is on steroids. He should definitely receive the prophylactic antiviral drug, that is Oseltamivir. It acts as a very good chemoprophylactic drug. Please give in that same dose. Dose is same. Duration is definitely 10 days, not 5 days here. You need to give them 10 days, 3 mg per kg per day, but it should be given in a once a day regime. So we will also see details of prophylactic antiviral therapy. So for whom we should give it? For all symptomatic children who are not at high risk, who are at high risk of this influenza complications with suspected or confirmed influenza disease, if treatment can be initiated within 48 hours of the onset. And any children less than 6 months, please remember we should be careful. We should start this in the OPD setting itself. And any high risk condition that predispose them to complications of influenza, we need to keep in mind and we need to start immediately. Next slide, sir. So preventive antiviral therapy should be the norm now, because every child, if you these children are going to schools and they are infecting the other children automatically. Please give advice as when the child is coughing so badly, don't let them go to the crutches, daycare centers or schools to infect other children. That is how it's rampantly spreading now. So we need to give this antiviral chemoprophylaxis for the prevention of influenza for all these individuals, especially those who are high risk individuals. And less than 5 years, they come under high risk. A pregnant woman comes under high risk. Elderly people who are, who have waning immunity, they are also come under high risk category. So let us protect our children. The entire family should be protected. First is the vaccination is what is very important. Once the child is started symptoms, you can protect the other high risk people in the family with a preemptive antiviral therapy.
Great. Really, that case is very interesting. So the sibling is having a nephrotic syndrome on steroid. So a great message that on steroid the treatment is given means the child has to receive the antiviral drug, not vaccine. Vaccine it should be given. It can be given after 8 to 10 weeks after the stoppage of the treatment of steroid treatment. So after 8 weeks, or that means 2 months, they can give the vaccination. But when the child is receiving steroids, here the important message: a nephrotic syndrome with a steroid treatment, they can receive the antiviral drug Oseltamivir for 10 days. That is the message what we want to give. And in severe cases in family also, the other children, other siblings can be given antiviral drugs, prophylactic drugs for 10 days. So this is the fourth case, sir. I request Sungoj Bhaskar sir, to start. Bhaskar sir.
Yeah, thank you, Dr. Sridhar. And this interesting case we had seen in the month of August. A 12 years old girl came to OP with fever and joint pains for 4 days, along with mild cough for 2 days. So we were little confused. 12 years old girl presenting with fever and joint pains. Age 12 years, gender girl, fever with joint pains. So probably we thought in terms of autoimmune disorders. Then the history extended by saying mild cough since last 2 days. Then when we looked at the child was restless with cough and low-grade fever. And arthritis, doubtful arthritis, mild arthritis was present. And when we auscultated, there were bilateral crepitations. So here we had a dilemma. Should we suspect any any autoimmune disorder along with flu case? So we knew that it's since the epidemic is going on, we thought it's a viral fever. Any viral fever can present with the same complaints, the same symptoms: fever, body pains, joint pains, and cold cough. But looking at the age and gender, we were we should also consider any autoimmune disorder. So when we sent CBP for this child, we had admitted this child because child was very irritable, but parents were very anxious. So when we examined the child, when we did the test, the CBP, once again, it was normal. We didn't mention ESR. ESR was not elevated. It was below 20 first hour. Then we did anti-nuclear antibodies to be on safer side. Fortunately, it was normal. And the chest X-ray was showing significant interstitial infiltrates. And as usual, we sent RT-PCR of nasopharyngeal swab. It was showing influenza type B positive. So here we could confirm that it's a case of influenza B respiratory infection. But there is an association between virus infections and connective tissue disorders, particularly interstitial lung disease. So frequent viral infections, particularly with influenza virus, can lead to interstitial lung disease in children who are prone to develop this disease. Or it can trigger and worsen the symptoms in children who have this interstitial lung disease. And as we all know, the cause of the interstitial lung disease, 30% of the times, though it is idiopathic many a times, but 30% of the interstitial lung disease is due to autoimmune disorder. That is, it is due to a connective tissue disorder. That's why we had we are presenting this case to our colleagues. And virus, as I told you earlier, it can trigger or worsen ILD in children who have this underlying connective tissue disorder. All patients, that's the reason for presenting this case is all the patients with coexisting illness. Just now we talked about asthma, we talked about immunodeficiency due to oral steroids. Similarly, all patients with connective tissue disorder should receive vaccination annually against influenza without fail. And whenever you suspect there is a viral respiratory infection, immediately and instantaneously start Oseltamivir early without waiting for the reports to come. So regarding clinical picture, regarding clinically to differentiate between influenza and influenza B, it's not easy to differentiate between influenza A and influenza B infections, but few things will help us uh, to probably suspect. That is, influenza A is a severe illness seen in adults and as well in children, whereas influenza B is mainly seen critically severe in children below 5 years. And above 5 years, they do have, but sometimes it's occasionally it will be severe in children above 5 years. The constitutional symptoms are severe both in A and B, and clinical presentation in children, it will be the same. Complications like pneumonia is more with influenza A. It doesn't mean that there will not be complications with influenza B. We do see complications with influenza B as well. But this another important differentiation is these mutations. They are more common with influenza A viruses, and that's the problem where we see new strains of influenza viruses which escape the immunity, which escape the antibodies, and they can cause new illnesses like we had seen so many pandemics. So mainly due to this antigenic drift and also antigenic shift, but drift is more important for mutations. Medical management, it is the same for both infections. And influenza A is seen not only in human beings, it's frequently seen in animal species also. That is why nowadays we are seeing more of zoonotic viral infections coming from animals to the human beings. Quadrivalent vaccine, it includes both the strains, A and B. In B, we have again two strains. It's to prevent all the strains of influenza A and influenza B. Next, please. Next, please. So, what are the preventive measures? This is more important. Before we get infected, if we follow these preventive measures, probably we can get rid of the infections. This pandemic 2019 had taught us many lessons, and some of them are like hand hygiene. We all know healthcare professionals. We know about the unhygiene of our hands and our mobile phones. So the most culprit in spreading the infections is our handshakes or hand touches. So try to wash your hands as frequently as possible with soap and water, especially after coughing or sneezing or after wiping a child's nose. And if you do not have water and soap, try to use alcohol-based rubs to to disinfect your hands. And particularly, we health care professionals should be very, very careful. And whenever we cough or whenever we sneeze, please cover your mouth and nose with a handkerchief or tissue paper. If nothing is available, try to cover your mouth and nose with your sleeve or with your elbow. Thereby, you can decrease the speed of the droplets and aerosols, and it can prevent to some extent. And secondly, we know these viral infections, they do transmit through fomites. So please clean your tabletops, your laptops, your mobiles, bathroom taps, door knobs, which are frequently touched by everybody. So particularly when our one of our family members or neighbors are suffering from the infections. This is non-pharmacological, and the pharmacological vaccination, vaccination. Nothing replaces the vaccination. Vaccination will prevent the infection, or at least it decreases the severity of the presentation. And thank God, we are getting this antiviral medications now, particularly for influenza infections. We have this wonderful neuraminidase inhibitor, Oseltamivir, which we have been using extensively in our inpatient settings. Thanks.
So, thank you, sir. This is a most interesting case. Why? 12 years child with arthritis, joint pains. That could be because of the connective tissue disorder, but ANA profile was negative. So the treatment was given for started with oseltamivir, child improved. But we should keep in mind the connective tissue disorders will flare up with the influenza-like illness or influenza virus. This can flare up and cause more inconvenience for the children. So that's why any these type of symptoms are there, we have to keep in mind. So influenza associated with connective tissue disorders are already cases are registered. So we have to keep in mind and start the oseltamivir, which will give a good response. So next, a few questions which are common, people are having doubt, doctors and also parents. So the first question to Subhoj Bhaskar sir: has the incidence of viral infections increased? What could be the possible reasons, sir?
So you are already told in your earlier introductory presentations,
Yes, sir.
the incidence of viral infections are increasing tremendously for various reasons, for various complex uh, reasons involved. So three main factors are: one is the human contribution for this increase of viral infections, another is our environmental contribution, and the third, the virus itself. See, our human beings, we are contributing to the increased incidence of viral infections because of the population explosion. The population is increasing enormously. Population density is increasing enormously, and intensified global travel across the world. People today they are in US, tomorrow they are in Japan or India. So extensive travel. This is also carrying viruses from one area to another area. And unfortunately, in developing countries, these public health measures are still very deficient, like clean water, proper sanitation. These things are not there. And above all, again, in developing countries, this malnutrition, undernutrition, leading to decreased immunity, leading to increased viral infections. And when you look at the environmental causes, deforestation. Now, all agricultural fields are becoming plots, becoming buildings, becoming commercial complexes, houses. Thereby, these animals, their zoonotic habitat is changing. The animals are entering into the human beings' residential areas, like you see particularly these leopards, and also climate change, global warming. All these are causing increased incidence of viral infections. And viral,
Yes.
lastly, the viral. These viruses are smarter than us. They are changing their what you call these genetic drift. They are changing their structures, and they are getting escaped through against these antibodies, against the vaccine-induced antibodies or natural infection induced antibodies. They are causing new illnesses, more zoonotic illnesses. So viruses also become very smart, and they are changing their genetic buildup and coming out as a new serotypes. So all these multiple reasons are leading to the increased incidence of viral infections.
Great, sir. Because it's a RNA virus changing genetic sequence very rapidly. So that could be the possible why viral infections are increasing day by day, sir. Next question to Pawan. Generally, how soon the child is brought to a pediatrician? Pawan.
Sir,
Yes.
yeah. Usually, how soon is the child brought to the pediatrician depends upon so many factors, sir. Like, the parents are well educated because in our area we can see them. Even within first or second day itself, they are coming rushing to the hospital because the flu comes with the symptoms of high grade fever and cough and severe cough, which is not tolerable by the parents also. So that's why they are rushing it a little faster. But the education is not that much, the facility is not much. I think some poorer parents, so they are maybe they are trying to give some syrups on the over-the-counter drugs like that, and these are the people who are coming little later to the clinic setup. But I think it's very important why they should bring it so early is oseltamivir is most effective when initiated within 48 hours. I think our academy also should run a campaigns so that the parents should be told that when these symptoms are found out, immediately rush to hospital. Don't even wait a day also. So that is what we need to give the message to the entire society so that once they identify these symptoms like flu, immediately they should rush to the pediatrician as early as possible.
True.
I have a question to Dr. Pawan and Dr. Sridhar.
Yeah,
See,
please.
we being very rational, particularly pediatricians, we always advise parents to wait for at least 2 to 3 days when your child gets fever, because we advise them that most of them are
Yes,
viral
yes,
fevers, they are self-limiting, they subside on their own. But here you are advising them to come on day one itself. So
yes, sir.
how do you propagate this message to the general public? Why?
Yes,
No,
sir.
actually, sir,
The
fortunately, sir, the season is such that because I'm seeing the cases, so these people are running on the day one only they are coming because the high grade fever, because it's not flu is not now this season, I don't know, but it's the fever starting with 103. They're not even, they don't have the time to start, wait for some more day. Child is really irritable, cranky. They have seen same similar cold cough fevers before, but they found that this time it is totally different. It's not like a routine, frequent cold and coughs which they used to have before. So that is making the parents to rush to the doctor immediately, sir. I think we need to really tell the parents that when you find that something ye hatke wala sardi kasi bukar hai, immediately rush to doctor.
Yeah, that's true. What happens is the why it's self-limiting means it depends upon the severity, sir. If severity is not there, then definitely child will improve. If the severity is more, like breathlessness, myalgia, headache, and child doesn't intake is poor, then definitely we have to advise them to come to the pediatrician or come to the nearest healthcare professional.
But
So
interestingly, the parents are getting afraid and bringing their children because the onset
Right.
is very abrupt, high grade
Very
fever,
abrupt. Very true.
sometimes chills and rigors, body
yes,
pain,
Yes.
unable to stand, unable to sit. So that's why they are becoming panic and coming, and within hours they are coming to us.
Very true,
that's
sir. Very true. Within hours, this time we are seeing within hours they are coming. Yes.
yeah. So the next question to Sungoj Bhaskar sir. Should Oseltamivir be started empirically or after investigations?
Yeah, we three of us dwelled very much on this question. Without any station, we had clearly told that Oseltamivir should be started empirically when you suspect influenza infection in a child who is admitted in the hospital. And a retrospective study reviewed 442 patients, and the median time from symptoms onset to Oseltamivir administration was 5 days. So the median time between the onset of symptoms and the administration of Oseltamivir was 5 days. And the subjects were divided into four groups. One group where Oseltamivir was started within below 2 days. In another group, it is 3 to 7 days. In the third group, Oseltamivir was started after the eighth day, and the last group started after 14 days of symptoms. And then the study outcome was, next slide please. The study outcome was, the earlier you start, outcome would be much better. Even if you start little later, definitely there would be some alteration in the severity and the duration of the stay. So the conclusion of this slide is earlier initiation of oseltamivir administration significantly reduced the occurrence and severity of pneumonia and shortened the hospitalization due to pandemic H1N1 in 2019. And even when administered little later also, there was considerable potential for reducing the pneumonia. That is the
Yes.
message of this slide.
Yes, sir. So better to give before 48 hours to start the oseltamivir. If not, also start the giving the things, so it will improve and patient will benefit about the and decrease the hospitalization. Also decrease the antibiotic use. And next question, Dr. Pawan. What are the factors on which clinical response to oseltamivir depends?
Yeah, there are several factors, sir, on which the clinical response to oseltamivir depends. Like the timing of the treatment is most important of all, and the patient age, influenza type, which type of influenza, like A or B, that also depends upon that because the resistance patterns are we are seeing now. Underlying health conditions like chronic comorbid conditions also influence the response to the treatment, and also the vaccination status. The children who are vaccinated, they respond better than those people who are not vaccinated. And the timing of the treatment, why we are stressing so much on the timing of the early administration of this oseltamivir within 48 hours is that will stop the viral shedding. Once the viral replication is stopped and the shedding is stopped, the transmission to the other people also we are stopping. That's a dual advantage we are having by starting it early, so that we are stopping the spread itself. So that is the way, that is the important aspect what we need to grade that. And what is important is the underlying health conditions also influence, like, immune status of the child, like, children with immunodeficiency states like malnutrition, which is very rampant in India, and chronic infections like tuberculosis, HIV, children of steroid therapy, like we have seen in the case, the nephrotic syndrome child with steroid therapy, he should be getting as a priority when such conditions are there. The more you delay, the response will not be that great. So these are some of the factors, sir, which we need to keep in mind about the response.
Yes, yes. So the virion release will not be there, and this
Very
virion
clear.
will not infect the healthy cells.
Very
That's the main
yes.
why we start initiation of antiviral therapy early. That's the main reason. So the
Exactly,
next
sir.
question
Exactly.
to Sungus Bhaskar sir. Generally, how long should oseltamivir be administered, sir?
Oseltamivir is proven to be used for therapeutic purposes and as well for chemoprophylaxis, for prophylactic use. So, as Dr. Pawan has earlier said, this card should be kept in our clinics, at least in our ICUs and clinics, at least for the time being, for a few more months. And this is it acts like it's like we can use it as a ready reckoner. But to make it very simple, I'll tell you, since we are pediatricians, if we remember 3 milligrams per kilogram, 2 doses for 5 days is the therapeutic dose of oseltamivir. Whereas for chemoprophylaxis, to prevent the infection in a uninfected child, it is again the same 3 mg per kg per day, single dose for 10 days. The only difference are for treatment we give twice a day, for prevention we give once a day. Duration of treatment is 5 days. Duration of prevention is 10 days. If we remember these two things, our job will be done.
Yes.
Thank you.
Great. So next question to Pawan. Do you prescribe antibiotics concurrently? Already we had, but the people who had joined late and commonly prescribes antibiotics. So since it's a viral, what is your opinion, Pawan? Do you prescribe antibiotic concurrently?
As rightly said, sir, flu is a viral infection and antibiotics are definitely ineffective against viruses, definitely. So, but we are, as a pediatricians, we are also scared. We ran campaigns like Rapstar that, overuse of antibiotics will lead to antibiotic resistance and all. So usually antibiotics are not typically prescribed for the management of flu in OPDs or in admitted cases unless there is a secondary bacterial infection. Please remember the secondary bacterial infections in terms of pneumonia, sinusitis, or otitis media. If they are coexisting with the flu, please don't hesitate to start antibiotics. As per the IMNCI guidelines, we can start this amoxicillin as the first drug of choice. You can start oral. So, and if the hospital policy has some protocols, and then you need to follow that hospital policy also. So, by and large, antibiotics are definitely not needed unless there is a secondary bacterial infections which is being evident there.
Yeah, great. So the next question, Bhaskar sir, how is Oseltamivir tolerated? Are there any major adverse effects of Oseltamivir, sir?
I think this question is very appropriate to me because in hospital, since last 5 years, we are using this medicine extensively. If you go to our wards, you will see this Oseltamivir with the brand name of Fluvac on each and every side table of the patient. Uh, it's the uh, tolerance is really good. Occasionally, there may be some nausea or vomiting. Even there, we don't know whether that is due to this Oseltamivir or due to the cough. But otherwise, major complications we didn't see them. But for our information, let us have these few serious complications in our mind. That is, it can lead to serious skin reactions like Steven Johnson, toxic epidermolysis necrosis, and other disorders like renal failure. These these three things we should keep in our mind because this drug gets metabolized in liver and gets excreted through kidney. 90% of it is through kidneys and 10% of it is through feces. So if there is any acute kidney injury or some amount of renal failure, dose adjustment is required. Otherwise, in my experience, I found it to be a very safe and effectively it can be used even in infants. About 2 weeks, it can be safely used, which we have been doing it.
Yes, sir. That's a great, sir. Very much well tolerated and doesn't have seen any side effects or adverse effects since 5 to 7 years. And the next question to Pawan, any contraindications or precautions to use of Oseltamivir?
So by and large, sir, Oseltamivir is generally well tolerated in children, but there are some contraindications and precautions which we need to know. So usually known hypersensitivity is for any drug. This is a major component, major contraindication. Hypersensitivity, known hypersensitivity to Oseltamivir or its components. So that is what is most important we need to see. And renal impairment, neuropsychiatric events sometimes rarely come with these like hallucinations, delirium, which is rarely known. And seizures also. What they say is oseltamivir may increase the risk of seizures in some patients, but we haven't seen so far. I think I'm sure that Sungos Bhaskar sir also might not be seen these complications, but they are noted here. And some drugs like dichlorphenamide and probenecid, which we are not using in routine practice, there is a chance that they can increase the risk of these side effects of this oseltamivir. Especially the drug in pregnancy, it is considered as a category C, where we need to outweigh the benefits versus risk, and we need to literally do. But whenever you are prescribing, please look into that any neuropsychiatric symptoms or any other adverse effects are coming, that we need to be vigilant always.
Great. So, summary is the proper diagnosis can and early treatment can prevent flu complications. Empiric use of oseltamivir reduces lower respiratory tract complications, hospitalizations, antibiotic use, and also WHO, American Thoracic Society, and Ministry of Health and Family Welfare recommends empiric use of oseltamivir. So, thanks to my panelists, Dr. Sungoj Bhaskar sir and Dr. Pawan Kumar, and also special thanks to Hetero Healthcare. So thank you. I'm stopping the screen sharing. Yeah. Please.
Thank you so much, Dr. Sridhar. Really
There was a
exhaustive and
small
very.
disturbance in the relays internet. That's why
That is,
unable to
that will
for
always happen. That will
the
always happen.
2-3 minutes.
But
Sorry
some
for
good,
that.
no, sir, no problem. Because these are going to happen, not in our hand. But some good insights, some practical insights into the problems. I'm sure the doctors who attended have benefited out of it, especially the case with the patient was on steroids. All these things will help our doctors practicing. That's exactly the insights that they want from senior doctors. Thank you so much, Dr. Sridhar. Thanks, Dr. Pawan Kumar. Thanks, Dr. Sankoj. It was a lovely session. I enjoyed it myself personally. Thanks, Nagadevi, for super support. Thanks, Smita. And thanks the sales team of Hetero for super coordination. Thank you. We can sign off, sir. Wish you a lovely weekend. Thank you.
Thank you, sir. Thank you so
Thank you,
much.
Hetero.
Thank you. Thank you, Hetero family. Thank you. Thank you, Dr. Sridhar. Thank you, Dr. Pawan.
See you.
Thank you, sir. Thank you so much, sir.